Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Today in my class, I'm going to touch upon the hemolytic uremic syndrome. Hemolytic uremic syndrome is a thrombotic microangiopathy characterized by microangiopathic hemolytic anemia, thrombocytopenia, and acute renal failure. It is a thrombotic microangiopathy characterized by microangiopathic hemolytic anemia, thrombocytopenia, and acute renal failure. Okay, it is rare condition, but potentially serious with variable etiology. It is very important to know the etiological factor that is responsible for this particular condition in order to have an appropriate and effective treatment to reduce mortality. So coming to classification, early rate has been classified as diarrheal and non-diarrheal. So diarrheal is associated with the bloody diarrhea with sugar toxin producing E. coli infection. Okay. Non-diarrheal is secondary to the a sort of activation of the indirect complement system. But in this, sugar toxin is not involved. But 30% of the patients have bloody diarrhea. So current classification is based upon etiological factors. That is typical HUS, atypical HUS, and secondary HUS. So the old classification of diarrheal, non-diarrheal has got certain drawbacks. In the sense, in non-diarrheal, it is not associated with a cigar toxin, but 30% of the patients have bloody diarrhea. Because of this, recent classification based on etiology is put into typical, atypical, and secondary. What is typical HUS? It is associated with sugar toxin producing E. coli. Okay, sugar toxin producing E. coli accounts for 90 to 95% cases of typical hemolytic uremic syndrome. It mostly affects children less than 5 years. Okay, it follows the consumption of contaminated food with STEG. Bloody diarrhea occurs 2 to 3 days following the exposure to contaminated food. Okay. Nearly 5 to 15% of the exposed persons develop hemolytic uremic syndrome. Nearly 3 to 10 days after the diarrhea, symptoms of HUS begin, characterized by fever, abdominal pain, vomiting, and bloody diarrhea. Okay. The patients also present with extrarenal manifestations like neurological, cardiovascular, in the form of seizures and altered sensorium and coma. With regard to cardiac manifestations, they develop features of congestive heart failure, pulmonary edema, and pulmonary hypertension. These are some of the features of hemolytic uremic syndrome, that is typical type of HUS. Coming to atypical HUS, its features are, it constitutes about 5 to 10% of the cases of HUS. It is due to genetic mutation leading to activation of the alternate complement pathway. Okay, it is due to mutation in the protein molecule that inhibits alternate complement pathway. That results in the activation of the alternate complement pathway, resulting in inflammatory injury to vascular endothelium. That leads to thrombotic microangiopathy. Okay. There are features of pallor, fatigue, somnolence as initial early symptoms, progressing to acute renal injury that presents with oliguria, uremia, and fluid overload. There is high risk of progression to stage 3 to 4 of chronic kidney disease and end-stage kidney disease in this particular type of HUS. Patients fail to recover without treatment. There is no spontaneous improvement in a typical HUS. Untreated, 50% progress to dialysis-dependent CKD with 25% of mortality. Look at extraordinary manifestations like cardiac and neurological are more common and are the causes of mortality and morbidity, with 25% of mortality in this particular type of HUS. Relapses are more common after recovery from initial episode. Okay. Hence, there is need to follow up and monitoring after the treatment is discontinued. Yeah. Coming to secondary hemolytic uremic syndrome. It is usually secondary to infection or other diseases. It accounts in nearly 5 to 10% of the cases of HUS. Strep pneumonia is the most common organism responsible for secondary HUS because it releases neuraminidase and also releases bacterial antigens which trigger complement activation and Coombs positive hemolytic anemia. This is the only condition associated with Coombs positive hemolytic anemia. So other causes include influenza viral infection, HIV, and SLE. Its presentation is similar to atypical HUS. Okay. Coming to a brief note on pathophysiology. Coming to typical HUS, it is common under 10 years, classically affects the children under 5 years of age. So after consuming the food contaminated with sugar toxin producing E. coli, that is TEC, these bacteria penetrate the intestinal epithelium, okay, binds with its receptors, TEC receptor complex, activates the complement, trigger inflammatory endothelial damage. Okay. Toxin as such is cytotoxic as well as also activates the complement pathway. So when there is inflammatory injury to the endothelial lining of the microcirculation, it triggers activation of coagulation cascade, which results in consumptive platelet aggregation. Okay, that leads shearing injury to the red blood cells as they flow through the microcirculation. That results in the microangiopathic hemolytic anemia. Okay, consumptive platelet aggregation results in thrombocytopenia. Okay, in classical HUS, Coombs test is negative. Okay, there is also release of cytokines, which perpetuates inflammation and organ damage. This is what the sequential effect of pathophysiology related to typical HUS. With regard to atypical HUS, there is activation of the alternate complement pathway due to genetic mutation of the protein molecule that inhibits the activation of complement. In secondary HUS, the infection induced by the bacterial antigens initiates Coombs positive hemolytic anemia in secondary HUS. There is activation of indirect complement pathway as in atypical HUS. Okay. Then subsequent events follow the pathophysiology as described earlier. Coming to the clinical presentation. Typically, children are less than 5 years in typical HUS. Presents with fever, abdominal pain, diarrhea, and vomiting 1 to 10 days after the consumption of the contaminated food. So nearly average period is 4 days following exposure to stick. Nearly 5 to 13 days after start of diarrhea, symptoms of HUS appear as oliguria, anuria, fluid overload, pallor, fatigue, appearance of fatigue, and bleeding manifestations. This is the picture in children under 5 years. When it occurs in adults during outbreaks of food contamination, adults, they present with severe neurological symptoms. Okay, and they have higher mortality more than that in children. Well, coming to atypical HUS, it initially presents with non-specific symptoms like fever, fatigue, and pallor. Diarrhea, even bloody diarrhea as in typical HUS may be presenting symptom. Renal manifestations of acute renal injury follow with oliguria, anuria, and fluid overload. Neurological and cardiac manifestations are similar to typical HUS. They account for the morbidity and mortality. Well, in secondary HUS, if pneumonia is the etiological factor, you can find features of pneumonia, features of empyema, sometimes meningitis. Coming to diagnosis, high index of suspicion is based upon travel history and dietary intake. So when there is high index of suspicion, you have to proceed with the treatment before awaiting the laboratory report, because if you delay the treatment, the outcome is very poor. So investigations that are carried out are complete blood counts with regard to hemoglobin, which may be low, total WBC count, which may be elevated if there is associated infection, and platelet count will be low. Then coming to the coagulation profile, you do the PT and APTT and D-diamers and fibrin degradation products which are elevated, and blood biochemistry shows elevated LDH, elevated serum bilirubin, fall in haptoglobin, increased plasma hemoglobin levels. There is disturbance of serum electrolytes like hyponatremia and hyperkalemia. Serum creatinine and blood urea nitrogen are elevated. Coombs test is negative in classical HUS and the atypical HUS, but it is positive in secondary HUS. There could be elevated S mileage if there is pancreatic injury, and there could be elevated blood sugar levels if there is insulinopenia due to pancreatic damage. So blood culture has to be done to identify any bacterial infection like streptococcus. And if the situation calls for, if there is a period of diarrhea persisting, stool culture and stool first toxin can be done. And testing for streptococcus and Shigella dysentery may be done if situation is called for. After rapid evaluation, proceed with the treatment. So waiting for the treatment to set in may result in the poor outcome. In typical HUS, fluid replacement to combat the hypovolemic shock, blood transfusion to correct the anemia, platelet transfusion to correct the thrombocytopenia and other bleeding manifestations. Avoid antibiotics and anti-motility agents in stuck HUS, okay? If you do admit antibiotics and antibiotic agents, they are going to worsen the prognosis. If there is associated Shigella dysentery infection or streptococcus infection, early antibiotic improves the outcome. In a typical HUS, early treatment with monoclonal antibodies like eculizumab, a recombinant monoclonal antibody that targets the C5 complement has to be done at the earliest stage of the disease. Prognosis and the outcome is good with the treatment with eculizumab. Well, revolutimab is also recently approved by FDA. And there is also a lot of guidelines with regard to the plasma exchange. With regard to secondary HUS, treat the cause and give the eculizumab. The prognosis is good. This is the brief account on the treatment. There have been good number of studies with respect to the treatment protocols and the guidelines in order to improve the outcome of the patients with HUS. I have given a very brief account in order to shorten the duration of the talk. Coming to the prognosis. Prognosis is generally good in children with typical HUS with an estimated mortality of 5%. If you initiate the treatment early, the outcome is good. The factors that determine the outcome are duration of dialysis and progressive renal insufficiency are the two important factors that determine the prognosis. Older the patient, higher the mortality. Eculizumab reduces the mortality due to end-stage renal disease from 30 to 9% in children. In adults, from 60 to 6% with a typical HUS. This is all the brief account on the hemolytic uremic syndrome, its current classification, pathophysiology, and the clinical manifestations, and laboratory evaluation, okay, and the treatment guidelines. I have not touched the detailed account of the various research papers which have proposed the guidelines for the management of various forms of HUS. Okay. Thank you for patient listening. This talk is especially meant for the postgraduates. Hope the postgraduates will be interested to see my video. Thank you very much once again. And I appreciate your feedback. Until we'll meet you again in the next class. And that time, thank you and bye-bye.